hyperacute stroke by anticoagulants, and we know that anticoagulant is not a real treatment. It's not dissolving the embolus, occluding the vessel. It's not opening the vessel. It's just, it prevents further coagulation of the blood, but it's not a real treatment. So the real treatment is to try to recanalize the vessel as fast as we can by the IV thrombolytic therapy that was shown to be beneficial starting from 1996 with an NINS trial that showed that giving IV thrombolytic therapy will have better recanalization rate and functional clinical outcome in the first 3 hours, and then it was extended 4.5 hours by the ECAT-3 trial in 2008. And later on it was shown that when we do a catheter and we go by our catheters and we try to open the vessel but by what we call the mechanical thrombectomy, we have better outcome when we have a large vessel occlusion compared to just giving the patient IV thrombolytic therapy. So nowadays we know that when we have a large vessel occlusion in the first few hours with certain selection criteria, the patient will have much better clinical outcome if we go for mechanical thrombectomy compared to just giving him IV thrombolytic therapy. This is a gold standard nowadays. And we have some imaging protocols that we do to be able to identify which patient will benefit from our treatment and which patient will not be a good candidate. So we have the MRI protocol and we have the CT protocol. In the guidelines, they are almost equal. There is no preference for the MRI or for the CT scan. Each one has its advantage and disadvantages. And the most important point is that it should be done rapidly, and it should be done in a standardized way. So actually some centers all over the world are using the CT scan and other centers depending on the MRI. But to do the CT scan, CT protocol or the MRI protocol, the importance is that it will help us in the selection of cases to identify which patient has penumbra and can benefit from opening the vessel and which patient will not benefit. And to identify also the approach of treatment, and we will see this later on, and to predict the outcome of the patient, which patient has a large core and he will not improve by opening the vessel, and which patient has a large penumbra and can be a good candidate for thrombectomy or thrombolytic therapy. If we use a CT protocol or MRI protocol, we have 5 main points that we have to assess. First is that we have to exclude the hemorrhage. We have to detect which vessel is occluded, because if we have a large vessel occluded, large vessels, that means carotid, M1 or M2 segments of the middle cerebral artery, A1 or A2 segments of the anterior cerebral artery. So if we have a large vessel occluded, we can go with a catheter and open it using mechanical thrombectomy. If it's a small vessel, so IV thrombolytic therapy will be enough, and we cannot go in a very small vessel by our catheters. We have to detect the core, the penumbra, and also the collaterals. And we have 2 main approaches for doing the mechanical thrombectomy whenever it's indicated. We have what we call the stent retriever and also the aspiration technique. The stent retriever is that we open a stent inside the embolus, and then we retrieve the stent while it's open. The stent is attached to a wire that we pull, and the stent is able to catch the embolus and get it out. This is one technique. And the other technique, the aspiration technique, we go up with a wide bore catheter that we put in direct contact with the embolus, and then we start to aspirate to be able to get out the embolus by the aspiration. We have 2 big trials, the ASTER trial that was done in France and the COMPASS trial that was done in the US. And both trials tried to compare which technique is better regarding the recanalization rate, the stent retriever or the aspiration technique. And it was proven from those 2 trials that they are almost equal. The stent retrieval and the aspiration technique, and sometimes if we are using one technique and it's not beneficial, we can shift to the other one. So in some centers they are depending mainly on the aspiration technique as a first line, and then if they fail they go to the stent, and vice versa in other centers. We know that also we have different types of clots, so we have that we get out of a patient. We have red cell clot and we have a fibrin clot that was shown to be more tough compared to the red cell clot, and because it's more tough, it causes more friction with the vessel wall, so it's more difficult to get it out of the patient when we have a fibrin clot. And the behavior also of the clot with the stent, for example, is different when it's a red cell clot or fibrin-rich clot. When we are using a stent for a red cell clot, the stent will be able, the clot will be entangled within the struts of the stent, so it will be easier to get it out. On the other hand, when we are using a stent for a fibrin clot, the fibrin clot is very tough, so it will not be entangled within the struts of the stent. It can slide over the stent, and the stent will get out without being able to catch the embolus. And that's why it was shown that using aspiration technique to get out a fibrin clot may be more successful compared to using a stent retriever for specifically the fibrin clot. This was shown in many studies actually. So if we can identify the type of clot before going for mechanical thrombectomy, this will be very useful to choose which thrombectomy technique to use, the stent or the aspiration technique. And that's why we had many also studies that try to understand the clot in the imaging that we do before treatment, before giving the IV thrombolytic therapy or the mechanical thrombectomy. One of the interesting studies showed that there is something that we call the susceptibility vessel sign, which means that when we do an MRI, the T2 gradient, if we have a red cell clot, it will cause a hypointensity that is larger than the caliber of the vessel. If we have this sign, this means that the type of this clot is more of red cell clot. If we don't have this sign, this means that this is more of fibrin type clot. So we can depend in the T2 gradient on this sign to be able to differentiate whether we have a red cell clot or a fibrin clot, and we will maybe choose the thrombectomy technique that we will use depending on this sign. We can have the same information also from the CT scan, so depending on what we call the clot density. So if we have a hyperdense vessel sign, the embolus occluding the vessel is hyperdense. This means that it's more of red cell clot. If we don't have the hyperdense vessel sign, we do a CT angiogram, we have a vessel that is occluded in the CT angiogram, and then we go back to the non-contrast CT scan. We don't have the hyperdense vessel sign where we have the embolus. This means that it's more fibrin clot, not a red cell clot. Also, we have other points that we can assess by the imaging before going for treatment, like the distance between the location of the embolus lodged in the MCA, for example, and the carotid. If we have a longer distance between where the embolus is lodged and the internal carotid artery, this will have better outcome in the IV thrombolytic therapy and even in the mechanical thrombectomy. Also, the clot length, for example, we saw in the studies that if we have an embolus that is longer than 8 millimeters, this means that the ability of the IV thrombolytic therapy to dissolve it will be less. So we can sometimes skip giving the patient IV thrombolytic therapy if we are at the end of the window allowed for giving the thrombolytic therapy. If we have a long embolus, and we can shift directly and go directly to mechanical thrombectomy. We have also a score called the clot burden score. This score was done to assess the amount of emboli occluding the vessels. So we have 10 points. We do a CT angiogram, and we start to identify which part of the vessel is occluded by the embolus, infraclinoid carotid, supraclinoid carotid, the MCA, M1 or M2, and we have 10 points. If we are at clot burden score 10 means that the artery is completely opened. If we have 0 means that starting from the infraclinoid carotid to the M2 branches, we have clots filling all these parts of the arteries. And for sure, when we have a higher clot burden score, this means that the ability of the IV thrombolytic therapy to dissolve it will be higher, and our ability to get it out by mechanical thrombectomy also will be higher. Another point is that what we call the clot permeability or perfusiveness of the embolus. We do a non-contrast CT scan, and then we inject the contrast in the CT angiogram, and we measure the density of the embolus before and after injecting the contrast. And if the contrast is able to go inside the embolus, this means that the embolus is not completely occluding the vessel. And this means that the embolus can be dissolved better by the IV thrombolytic therapy, which will be able to go inside the embolus better. And it will be easier also to get it out by mechanical thrombectomy because it's not a tough embolus completely occluding the vessel and adherent to the wall. So to sum up, the density of the clot, hyperdense clot, will be retrieved better by stent retriever, or let's say that the embolus that is not hyperdense will be retrieved by aspiration better than by stent. the location of the embolus, the distance from the carotid, the length of the embolus, the clot burden score, and the permeability of the embolus. All these points can be assessed by the imaging before going for the treatment, and depending on what we find in the imaging that we do, we have certain prognostic values for what we have mentioned, and we can also choose, as we explained, which device of mechanical thrombectomy to use. I will end by showing this embolus. This is one of the cases that we did. I think this is the longest embolus that I've ever seen in my life. It's more than 3.5 centimeter in length that we got out from a patient as one piece. This is before on the left side, and this is after. We got it out using both techniques together. Sometimes we use both techniques, stent and aspiration, both together, and we were able to get it out as one piece from the first pass. Thank you.
Thank you, Dr. Farouk, for this interesting lecture.